And good evening. Welcome to November's Aging Well. We're so glad you're here. We've had the craziest weather for those of you who aren't from Winston-Salem, North Carolina. But you know what? I've heard it said wherever I've lived, if you don't like the weather here, wait a day, wait an hour, and it'll be different. And that's kind of how we are here. So I want to thank our crew, Tom Roth, Courtney Hayes, and Audrey Bell Farrow for always being the ones that make this program work. So thank you, thank you, thank you. So grateful to have you. You know, we are approaching the holiday season and the food is kind of heavy, and sometimes it can become a little bit predictable. And that's why we're tickled to death to have a feature of the cooking show tonight talking about something entirely different than the standard turkey and dressing and heavy sides. So we have got Chef Alex Governale. He is with the Butcher and Bull restaurant in downtown Winston, and tonight is going to be a feature on downtown Winston. He's going to be showing us how to create his ancho rubbed flank steak with avocado cream and corn and black bean relish, and it was amazing. So Chef Alex, go ahead and show us how to do it.
Thanks for having me, Deb. We're here with Aging Well. I'm Chef Alex Governale down here at Butcher and Bull in the heart of downtown Winston-Salem. And today we're going to make a beautiful flank steak for you. We got a local flank steak from a farm here in North Carolina called Brasstown Beef. I love shopping local as much as possible. I always can get you some of the best products and some of the best produce you can get. To go with that, we're going to do a little bit of an avocado cream and a corn and black bean relish, kind of warmed up. So what we're going to do first is we'll create the spice rub for our flank steak. So I got a few seasonings here. We got about a tablespoon of salt, pepper, and ancho chili powder. And then after that, we have about a tablespoon and a half, roughly, do how much you like your garlic, of garlic powder and paprika. And then last, we have about a teaspoon of cumin and onion powder. So we're going to go ahead and give that a mix up. Okay, so we're going to go ahead and unwrap our flank steak here. Try to get you a nice even cut. Your butcher can do it, or if you need to, you can do it yourself. Save your trim. You can always use it to make something like a beef stew when it's a little colder, or you can use it to even make your own homemade beef stock. So what we're going to do is we're going to take a little bit of our seasoning here, get it nice and coated on all sides. And we're just going to let that kind of sit for a sec while we get some of our other ingredients together. So you want to have it nice and coated evenly as much as you can. And take these gloves off here. We're going to go ahead and get that avocado cream so it's ready for us when our steak is done resting. We'll just be ready to go. So take your knife, your avocado, give it a good peel, twist to pop it off, knock that off. Then I got my blender here. Got to take both halves of the avocado, just take a back of your spoon, scoop it out. And then what I like to do to go ahead and make, I do this a lot for my own dishes, is I add a little bit of Greek yogurt to a lot of things. Adds you a little bit of extra protein and just kind of makes everything creamy and a little tangy. So I have about a quarter cup of Greek yogurt and a quarter cup of heavy cream. I know I said healthy, but we got to get the texture right. So go ahead and throw that in there. Got this towel, wipe my hands off. And I have about a tablespoon and a half, 2 tablespoons of cilantro. It really depends on how much you like cilantro. I'm a fanatic, so I add a little bit more on my own. Then we're going to take about half a lime. Squeeze that in there. And about 2 cloves of raw garlic. If you got a good blender, it'll chop it all up for you, no problem. Slap this on the blender real quick. And helps if you turn it on. We're gonna add just a whoop. Slide that back in frame, make sure you can actually see me. All right, so we got it a little thick, so what we're going to do is we're going to add a little bit of oil and kind of blend it in. There we go. And so you're going to have a nice, almost sour, kind of thick sour cream texture, and we're going to put that on the plate when we're done. All right, slide that off to the side for a sec. So what we're going to do now is we're going to go ahead and start grilling off our steaks. With a flank steak, you want to give it plenty of time to rest. If you don't, it's going to be kind of tough, and it won't have that even cooked throughout. I'm going to just set it right over here on my grill. Get some nice marks on it. I'm going to go for a nice medium rare, so we're going to let that go for probably about 3 minutes aside, and then we'll flip it and see how it looks. I wish you could be in here with me. That smells pretty great right now when it hit the grill. All right, so we're going to go ahead and get our corn salsa together. So we're going to take a pan with a little bit of neutral oil, like canola or avocado oil. Get the grill going. About a medium low. Don't want to get it too hot. While that preheats, we're going to chop up our onion. Ends off, straight through. Take a peel. So I'm going to go pretty rough chop on this. I don't want it too fine because we want to make sure our onions don't burn. So I'm just going to go one through the middle. And then a few through that. That should be about enough. You're going to want about half an onion worth. I'm going to set that off to the side. And so first we're going to start with our corn because I want to get our corn a little roasted and a little charred. So we're just going to put our corn in there and let that get kind of heated up. And while we do that, we're going to check on our steak over here. See how we're looking. I'm going to give it like a little half turn so we can make some nice marks on it over there. All right, so now we're just going to kind of let our corn saute over here. You're going to want it to not quite start popping like popcorn, but you're going to want to get a little bit of marks on there, a little bit of color. So next thing we're going to do while we wait on that is we're going to put a little bit of roasted red pepper and tomato into our corn. So we'll go ahead and kill 2 birds with 1 stone while that's cooking and get everything together around the same time. I'm going to just go ahead and take, this is just a beef steak tomato. Again, when you can shop local, do it as much as possible. I'm sure there's a local farmer market wherever you happen to be. And as much as possible, we'd love to support local farmers. So we're going to cut it pretty much how we slice the onion. If I'm going a little fast for you, don't worry. There's going to be a recipe online for all of this, so you'll be able to follow along at whatever speed you need. Go ahead and give that a little toss. All right, so you see your pan starting to get kind of hot. So by the time our onions finish cooking, our corn should have a nice color. So we're just going to go ahead and slide our onions in here. Give that a little bit of a toss. And now this is probably going to be the longest part about making this particular dish is we want to make sure those onions are cooked pretty well. If not, you're going to get that really pungent onion breath, and we don't want that. We go ahead and flip the steak one more time. Got some beautiful looking char marks on it over there. All right, so we got the onion diced, we got our tomato diced, and last we're going to dice up a roasted red pepper. Now, the best way to roast these on your own is if you don't have a nice gas grill like me, is you can put it in your oven on broil, a little oil on it, and let it cook for a while, and then you pull it out, cover a towel, and you'll be able to peel that skin right off and have a beautiful roasted pepper of your own. So again, we're just going to cut these into about bite-sized pieces. All right, so that's everything together, ready to go. So the only things we have left to add to this is going to be our tomatoes, our black beans, and a little bit of our roasted tomatoes. Our steak is looking great over there. Give it a little toss. All right, so what we're going to do now, we're going to take a look at our avocado cream. All right, slide that out of the way. All right, and just because you're cooking at home doesn't mean you can't make food look beautiful just like we do down here at the restaurant. So I'm going to slide this out of the way a little bit, give us some more working space. We'll set that right there. There we go. So we'll go ahead and make this nice and beautiful just like you'll see at the restaurant down here in Winston. I'm going to put a little bit on the plate. Feel free to be generous. This is going to be your sauce for the steak, so feel free to put on as much or as little as you like. Give it a nice little swoosh. So when you do that, you're just taking your spoon, just rotating the wrist a little bit. Little trick for you guys there at home. Go ahead and impress somebody you love. All right, so there you go. Hear that pop? And that's how you know your corn's getting there. All right, so next we're going to go ahead and add in some of our black beans. So this is about 2 cups of black beans, 2 cups of corn. Get that tossed together. Add in our peppers. And at this point, we're just going to kind of add everything in here so they can get to know each other a little bit. Just give that a few more tosses. All right, let's check our steak over here. We're just about there. I'm going to give it one more rotate so we can finish getting those nice diamond marks. All right, so we're going to steal a little bit of our spice rub and we're going to add it to our mix here to make sure we're really well seasoned. Add a little bit in there. Give it a few tosses. A little more. There we go. You see we're starting to get a nice kind of uniform color from that seasoning mix. It's going to make everything just a little bit orange. Just get everything a little bit orange with the seasoning mix. All right, there we go. All right, last step for that is we're going to add some more fresh lime juice. I'm just going to give about half a lime worth of a squeeze. Really want to make sure we bring that flavor through. So we want to make sure we stay nice and light with our flavors and really bright. Sounds like our steak's done over here. So what I'm going to do is I'm going to flip this guy over. And grab our steak. All right, now this is the hardest part for me. I want to slice into this right now, but you got to let it rest. Trust me. If you don't let it rest, you're going to bleed all over your plate. It's not going to look pretty. You're not going to have that even, clean cook that you're wanting to have. All right, so our mix over here is just about done. So we're going to get a few little garnishes together for our plate to make it look nice. So we're going to take the other half of that lime that we have. We're just going to cut off a nice little wedge. I'm going to take a little bit of our leftover cilantro that we didn't put in our cream. Just give it a nice chop. All right, there we go. All right, so next, let's go ahead, give it a few more little tosses. And now you can cook this pretty quick like I did, or you can really let it kind of go for a little while. But make sure your pan's not too hot or it'll start to stick to the pan. But you can really let it go low and almost simmer and you'll get a really nice depth of flavor in there. So we're going to take a little bit of our mix and we're going to stick it right inside of that little hole we made with our swoosh. Yes, swoosh is the technical term. All right, here we go. So I'm going to throw one more glove on before I slice our meat. All right, let's go ahead and give us a little slice here. So with flank steak, and a lot of your meats in general, you're going to see a grain. This one's pretty easy to see because it's has it pretty wide open. You want to slice against that grain. That's going to go ahead and cut through the proteins and make your meat a lot more tender. If you cut with it, you're going to be chewing forever. So I'm going to go ahead and just give a few slice. Give us a nice medium rare over here. Look at that. Then we're going to go ahead and kind of fan it out a little bit. I have it all where it's one side and then fanned out. Let some of the juice drain off. Right on top of our corn salsa there. Throw our lime wedge right there. And a little bit of chopped cilantro on top. And that is our ancho rub flank steak with a little bit of avocado cream and a roasted corn and black bean salsa. Again, this is Alex. I'm down here at Butcher and Bowl in Winston-Salem. Really happy that I get to work with the AgingWell program and bring this information to you. And also, glad you guys could indulge me a little bit and I got to pretend like I was on the Food Network for a little while. So I really appreciate you tuning in, and I hope you enjoy. Thank you.
I really do think that, once Thanksgiving comes, we are going to be eating so much holiday food. This just smelled amazing. So I think this will be a wonderful treat and something certainly different from the standard traditional holiday fare. So speaking of fare, oh, wow, how was that for a transition? I am so looking forward to our Craftsman, the Piedmont Craftsman Fair that's going to be this weekend coming up. And to give us a little preview of a lot of the artists that are every day in the gallery down on Trade Street, and to give us a preview of some of the artists who are going to be featured at the fair, is actually going to be taking place at the Benton Convention Center. This is definitely an event you do not want to miss. So I want to make sure I get all the names right. Jane Dabb, Gretchen Siebert, and Chris Ashen Haynes. that are going to be giving us a tour of the gallery, as well as a little taste of what's to come with the Craftsman Fair. Enjoy.
Thanks, Deb, for joining us here at Piedmont Craftsman. I'm Jane Dabb, and this is Gretchen Siebert, and we're excited to be part of Aging Well. And as you can see, we have an event coming up next week at the Piedmont Craftsman Fair. It'll be at the Benton Convention Center next Saturday and Sunday. We hope you can join us. As you can see, we're standing in front of Piedmont Craftsman's Gallery here on Trade Street in downtown Winston-Salem. Come on in. We want to show you some of the fine craft that we have from our artists.
Hi, my name is Gretchen Siebert. I'm the Director of Operations here at Piedmont Craftsman. And as you can see, we are inside our gallery here on Trade Street. And so our big event of the year is coming up November 18th and 19th at the Benton Convention Center, the Piedmont Craftsman's Fair. So Piedmont Craftsman is a nonprofit guild and gallery that represents fine craft artists, meaning potters, weavers, fiber artists, printmakers, blacksmiths, metalsmiths, jewelers, woodworkers, anyone who works in a fine craft medium. And so we represent about 300 craft artists currently, or at any one time. In the gallery, so sometimes we have a lot of our craft artists will bring work to the gallery. Some only do the show, some do both. So there's always an opportunity to discover an artist working in an interesting medium, in an interesting way. Piedmont Craftsman was started in 1963. So this year is the fair coming up actually is the beginning of our milestone anniversary. And so it was founded by a group of craft artists who were friends, along with collectors, at Mary Goslin's kitchen table. And so from that conversation came Piedmont Craftsman. So every artist you see in here was juried into the gallery, so by a committee of their peers. And so we represent artists who are working at a very high technical level and who have a clear vision or clear voice in their aesthetics. And let's see, so kind of for instance, we have Michael Smith is one of our potters who is in here in the gallery. Sometimes he does shows, or sometimes he does the fairs. This year he's just sending us work to the gallery, but he works in this kind of textured volcanic glaze, which it feels like pumice. But he is, working in a very difficult glaze technique. And so a lot of our artists, craft artists, are often very innovative in what they do. Oftentimes they invent techniques or are perfecting techniques. Some craft artists invent like glazes, invent joinery, invent beading techniques. We also have a lot of craft artists who have come from a science background, which is pretty exciting. So we have, let's see, Marie Wright is one of our potters who was a researcher. We have Ray Jones was an aeronautical engineer and makes these beautiful kind of aerodynamic looking kind of wood cabinets. We have, let's see, we've had other biologists, we've had other engineers as craftsmen, which is really exciting to be in a world where both art and innovation kind of come together. So we are a nonprofit. We're a 501c3 education nonprofit, and our mission is to promote the value of fine craft. And so another, something else I can tell you about Piedmont Craftsman is that we have an education arm. So two major programs in our education program is that we do artist residencies in public schools, and then we have craft demos throughout the weekend at the fair. So we usually have between 16 and 22 demos happening on Saturday and Sunday. So we'll have a clay demo area and kind of like a non-clay demo area. where you can come and watch these demonstrations that are, part of what you get with your admission. And we have a lot of people just come for the weekend and watch and learn from the craftsmen sharing their techniques with us. And it's really fun to watch. You can get up close. Some are more chatty than others, so it kind of depends on who will take questions and who wants to just kind of, get involved with what they're making and have you just watch. But it's very exciting. And we also do lectures, we have artist talks, we do panel discussions, and we also have partnerships with other organizations in the area. I invite everyone who is interested in the arts or in craft or in culture to come visit Piedmont Craftsman and check out the gallery, check out the work. We're always happy to connect you with artists that you're interested in. We love to have a personal connection with, with whoever's involved with us, whoever's interested in the world of craft, and connect our artists with those folks. There are a number of ways you can get involved with Piedmont Craftsman. Always come to our events. That's probably the number one. Art needs an audience, and we need lovers of art to come and hang out with us and bring your friends. And at the fair especially, that is like it's not just a beautiful marketplace and kind of craft demonstration kind of extravaganza. We have a lot of people, it's a social event as well. It's very, a lot of people come and meet friends and hang out and just meander through the fair and look at, works of art as you would do at a museum. Other ways you can get involved is we always need volunteers at the craft fair. We need help. So we have booth sitters, which means that you can come by and while the craftsmen are taking a lunch break, you can babysit their work and maybe talk to a few buyers and see who else is coming to the fair. We need help at the info table. Let's see. Yeah. Other ways you can get involved are we have a volunteer board. You can also be on a committee. You don't have to be on the board to be on a committee, but we have several different kinds of committees that, whatever area of interest you'd like to be involved in, you can give us a call or send us an email, and just you can help us spread the word about Piedmont Craftsman. Also, if you know craftsmen or if you yourself are a craft artist and are already in the craft world or looking to enter into the craft world, we have a national call for craft artists every year, starting in January, and we put that out via social media. And we have craft artists who of all ages, beginning in the world of craft, or if they've been veterans in the craft world, coming to Piedmont Craftsman. Piedmont Craftsman, despite the name, we are a national organization, so we do represent artists throughout the U.S. A lot of our artists are still in North Carolina and in the Southeast, but we have a pretty far reach, and we're always looking for new artists to join us. I'd like to introduce you to Chris Assumption Haynes, our gallery director here at Piedmont Craftsman. And Chris is going to take us on a little walk around to show us some of the art and artists in the gallery and who may be at the fair.
So Winston-Salem is now considered the city of arts and innovation, and part of it is around here. We'll take a look at some artists who are actually going to be at the fair, starting with this artist right over here. Okay, so one of the artists that's going to be at the fair is Cara Bevan. She is one of our newest artists. She joined with us this year. This is a selection of her work here, and a lot of people say it looks like clay, but it's not. She actually makes these out of gourds. So these are all gourds and a little bit of clay carvings. And you can tell sometimes because if you shake them, you can hear the seeds. But they're all numbered, they're all signed. She has really great detail on her pieces. We have all different kinds of things. She has the dragon, the turtle, the octopus, the dogs. There are a couple of really lifelike looking snakes at the front counter. and she's really amazing. She makes all different sizes. And she's also one of the younger members of the guild, which is great. We want to get more younger members in, just kind of for the variety and for what their point of view. And so she will be at the fair. Another one who will be at the fair is this guy here, David Roswell, another one who came in last year. He's a clay artist from Durham. He does, I believe that's wood fire clay, really nice functional work. He's also known a lot for the lamps he does, which when you get to the fair, you can see his lamps, which are really, really pretty. See behind me here with the fiber work, one of the artists who's always at our craft fair is Liz Spear. Let's see if I got one of these. This is one of her coats right here. Really pretty work. She also does commission work as well. So you can actually talk to her. If you want a commission coat, you will actually be able to talk to her about getting one for you in size and everything. And she's really great working with customers. And she is from Asheville. Another artist will be Tim Sullivan. These are some of his. This is actually glued down just in case. He does slip work with his, it's a really high fired slip work, so it has a really pretty finish and glaze to it. He's another one. He's also a member of our board, I believe, and he will be at the show as well. This is another artist who's going to be at our fair. He is one of our newer artists. His name is Brian Brace. He's from Black Mountain. He's a furniture maker. He's been doing this for quite a while. If you've been to the Southern Highlands show, either in the spring or the fall, you may have seen him there. He is really an excellent woodworker, basically in like a more mission style. This particular piece is one of his side tables. There are two, if you're interested. He does have the other one. He will be at the fair within a full line of his work. It's all really well made. These features here, these curve features, are actually a regular feature in his work. So whatever you find in his tables, chairs, etc., this will be a part of it. It's like his signature piece. Another one where you'll see a lot of is jewelry. One of the artists that will be there is a local artist. Her name is Annie Grimes Williams. She works with enameled bronze. So the cool thing about her pieces is that you have one color on one side, another color on the other side. Sometimes she does textures. One other feature of Piedmont Craftsman is in the gallery we carry a Artist of the Month show. This current Artist of the Month show features two artists. The first one is Cynthia Aldrich. She is a clay artist from the Triangle. And this show features, she's done both functional and sculpture. This show features her sculptured women throughout the show. The show itself is called Stillness and Movement, which is reflected in sort of the Zen qualities of both this artist and the artist on our wall, which is the other Artist of the Month, Richard Mayberry, who is a print artist from Pisgah Church. And his are all woodblock black and whites with some etchings as well. So this show will be up to view through December 2nd. So that's just a sample of some of the people who will be at our fair next week.
Going to this fair is really one of the highlights of fall for me. So I hope if you're in town and you are around and able to attend, it really is something fun. And so I'm tickled to death to introduce our educational speaker for tonight, Dr. Oona L. She is a clinical associate professor for the Department of OBGYN at the Wake Forest School of Medicine. And, she's here to talk about issues that affect us women that as we age may become common, but don't necessarily have to be the norm. And I'm just tickled to death to learn about that from her so that we can all improve our quality of life. So Dr. O'Neill, I'll turn it over to you.
Thank you, Deb. I want to thank everybody here for your attention and for your interest in aging well from an OBGYN's perspective. Yep. Give me 1 second to just clean up my screen here. Great.
Yeah, it looks great.
Okay, great, thank you. So my name is Oona O'Neill. I'm a general OBGYN here at Wake Forest Baptist Health. I've been here with the School of Medicine for approximately 16 years, and it's my pleasure to talk with you today. I hope I don't lose the men in the audience today. While we are talking about female issues, I promise I will not be too graphic. And I think we all know that anything that affects a woman will also affect a man. I think you can ask any husband that and get a chuckle out of that. So the other thing I wanted to bring up is some of these issues women don't always want to share openly with their spouses. And so this is something for you to look out for your own woman's health, to ask about and inquire about and also know about. So I'm just having a little bit of trouble advancing my slides correctly. There we go. Okay. So in terms of aging well, we're going to talk about the usual suspects.
They haven't advanced.
Oh, they haven't.
No.
How about now, Deb?
Nope, not yet.
I'm sorry. I'm going to reshare my screen.
Okay.
Is it there now?
Nope. This looks like your email, your Outlook screen.
Oh, sorry about that.
It's all right. I don't know if you can jump in and help her.
Yeah, maybe just stop sharing again, and then if you've got the PowerPoint running, just go ahead and share just the PowerPoint, not the whole screen. See if that helps.
Is it up now by any chance?
No.
Nothing's being shared at the moment.
It's you.
Oh.
Yeah,
I'm sorry.
that's all right. Okay.
And how about now?
Now it's perfect.
Okay, I'm so sorry, everybody. That is so frustrating. To get back to the point, when we're talking about the female issues, I talk about the usual suspects, which are non-cancer related conditions very commonly experienced by women, as listed here. And then I'm also going to talk about the cancers and specifically what you have to look out for in terms of signs or symptoms of cancers. So one thing that gets very confusing is we have so many specialists in our field now. So I wanted to explain to you who the doctors are and who the players are in various specialties with whom you can share whatever symptoms you're having. There's a general OBGYN like myself, an obstetrician and gynecologist, and we both deliver babies, but also perform surgeries for women and deal with all the different aspects of medical care that involve the pelvis. There's a general gynecologist who does not do the delivering babies piece, but just the gynecology. There's also a urogynecologist whose specialty is officially known as the female pelvic medicine and reconstructive surgery. That's a mouthful, but these are specialists who, in addition to training in general OBGYN, do an additional 3-year fellowship specifically related to surgeries involving the pelvis. And those are the surgeons who interact with patients who have pelvic prolapse type symptoms. You also have urologists who can deal with both male and female issues specifically related to the bladder. Primary care doctors, that's an internal medicine doctor or a family physician. or a gerontologist, who also can be a gateway into talking about your symptoms. And then specifically for cancers, there's gynecologic oncologists. I wanted to introduce the concept of what the pelvis is. So if you please read this slide left to right, you first can see just the bony pelvis in the center of our body. The next slide, you can see some pictures added of the rectus abdominis and leading into muscles that lead into the thigh, and that all crosses over the pelvis. Moving forward, you can see the muscles that lie across the sacrum and on the bottom kind of platform aspect of the pelvis. Moving down below, you can see then added on where the intestine lies and where arteries and veins lie in the pelvis. And then lastly, putting it all together for us is where the female organs lie in the pelvis as it relates to the center of gravity for our body. So what this really tells us is the pelvic floor is really the center of life. If the center of your body is really the platform and the basis for your physical activity, all the things that we like to do involve a working and functional pelvis. And men, these are the things that could be keeping women from being fully functional in their daily lives and their daily activities, whether or not that includes running a family, helping you with your issues, and just daily grocery shopping, getting in and out of a car. You need an adequate functioning pelvis to do that. So the first thing I wanted to talk about is pelvic organ prolapse. And so I have the definition listed here, but basically what that feels like is just a dropping or a herniation of the organs that are in the pelvis. And you can be asymptomatic and not have any idea, or you could feel pelvic pressure. So this picture here describes the major players when we're talking about the pelvis. So there is the bladder, the uterus, and the rectum. And each of those lies kind of on top of them, the bladder on each other, the bladder on top, followed by the vagina, followed by the rectum. And in the lower portion of the slide, you can see if the bladder is falling, what that looks like, followed by in the middle slide there, if the uterus is falling versus if the rectum is falling. And when we examine women, we can see this when we do a pelvic exam, like a normal pap smear. We can actually see the herniation of these organs on a routine exam. Here you can see on the left, just again, the bladder, the vagina, and the rectum are the major players that we're talking about. And on the right, you can see this is a cervix and a uterus that has started to fall in the vagina, and that's what that would look like from a physician's exam. Pelvic organ prolapse, stress urinary incontinence may be related to it, and the intervention for this starts to increase with age. And that's what this graph just shows you. Around middle life, 45 to 65, we start to see these issues arise, and American women are approaching getting surgical intervention done as their age increases. So this is certainly something to know about in terms of aging well. Pelvic organ prolapse truly is a common reality. And I think in our older generations, we don't talk about this as much. We have become more brazen, and we are talking about our symptoms all around the body more. And really, this is an age-related phenomena. And a lot of that has to do with just your regular connective tissue. So even in your face, you notice that people can get facelifts because the connective tissue starts to drop a little bit. Well, that same connective tissue is actually in your pelvis. It's not cosmetic, however, because that connective tissue interweaves between your organs to hold them in place and help them function anatomically and correctly. So half of all women are dealing with pelvic organ prolapse in some respect by the age of 80. How do you recognize pelvic organ prolapse? Well, symptoms vary for everybody. The most common thing I see in my office is a woman will come in and say, I feel like I'm sitting on an egg. And that's precisely just the falling of the organs. They can feel that in their pelvis, and they feel that pelvic pressure. Sometimes there is associated urinary incontinence, but not all the time. In terms of risk factors for people to develop pelvic organ prolapse, again, half of all women are going to experience this. We see an accelerated aspect of this around menopause when hormones change for women and there's a decrease in estrogen. Also, any diseases that a woman might have that already weaken connective tissue, that includes lupus or Ehlers-Danlos syndrome, can make you at an increased risk for your connective tissue in your pelvis to also droop. Any prior pelvic floor injuries, childbirth being the most common one, but also bad falls and car accidents can do that. And from other chronic medical conditions that would increase your abdominal pressure, that puts more pressure on the pelvis and can make that connective tissue fall. What does it feel like? The overriding sensation that women will feel is just a pelvic pressure. Now, men, I want you to understand that feeling is not something that a woman is necessarily going to talk about openly on a daily basis, but that is what she's feeling. It's usually worse with gravity and with walking. So particularly at the end of the day, that's when women tend to be most symptomatic. With the associated urinary incontinence, that can require wearing pads. Those pads can be very irritating against the skin. And any of the prolapse that is exposed to the air because it's outside of the body can also get very irritated and be uncomfortable as well. So that's what women are potentially dealing with, which they may or may not be sharing with you and talking about. There are several treatments for pelvic organ prolapse, and I'll go through some of the main players, but I wanted to talk about lifestyle changes. Particularly increasing core strength can make a difference. There's non-surgical intervention with pessaries and pelvic floor physical therapy. I'll talk a little bit more about that. I'll tell you, pelvic floor physical therapy has made strides over the past 20 years. As a physician, 20 years ago when I started doing this, kind of poo-pooed it and thought, oh, what's that going to work? Physical therapy, who has time for that? Who's really going to do that? And then my patients started to go, and it has been a game changer for women. And I have been very impressed with how effective physical therapy can be for the pelvic floor. So if that is ever brought up as a treatment option, please consider it because it has markedly changed women's lives. They have avoided needing further intervention, avoided surgeries. It's something to definitely look into. Finally, I will talk about surgical intervention, and either general OBGYNs or gynecologists perform surgeries, but now more often it's a specialist, a urogynecologist, who perform these surgeries. Very quickly, I wanted to introduce you to what a pessary is. A pessary is a small silicone or plastic dish that can be placed inside the vagina, and they come in all different shapes and sizes. A pessary itself does not cure pelvic organ prolapse, but it does lift and give support to those tissues, which can be comforting for that pelvic pressure. And it's a non-surgical intervention. Pessaries can be placed by yourself. Most women cannot place a pessary by herself. So a doctor or a provider can do it, and you have appointments every 3 to 6 months, depending on your situation, to have those pessaries removed and replaced. So that is an option for people and something to know about. Additionally, we have surgical options. These are very big medical words that are hard to pronounce, but I wanted to go over the colporrhaphy, which is 70% effective, is the original traditional surgery that we perform. 70% effective means that 30% of them fail. And that doesn't necessarily require reoperation, but in the surgical world, we don't like a 30% failure rate. So we have better procedures that we've come up with. Those include a uterosacral or sacrospinous ligament fixation, and that's 80 to 85% effective. That is a vaginal procedure. A sacral colpopexy, which is 90 to 95% effective, is the gold standard treatment for pelvic organ prolapse. And then there's a colpochliesis as well, which means to close the vagina in Greek, and that is an option that works very well for some women. All of these surgeries are not major surgeries that require an extended hospital stay. These are all surgeries that are performed on a same-day basis, so no hospital admission unless you have other medical conditions where it would be safer for you to be admitted in the hospital. So we have really come a long way from what our prior surgeries used to be to what we can provide now, and they're much, much more effective. This is an example of a sacral colpopexy, and this is just mesh that is woven around the uterus, and it's attached to the tailbone in order to hold that aspect up into place. And that is very effective for uterine prolapse. The sacrospinous fixation is when you actually put suture into the top of the vagina and you suture that into the sacrospinous ligament. Again, all part of the bony pelvis and all proven to be very effective as well. And lastly, a colpoclitis is literally to close the vagina. I have just a little diagram of that here to show that that is an effective and possible solution for women. So I know we don't love to jump to surgery all the time, and I'm not suggesting that you have to, but if it becomes necessary, you function much better when your pelvis is intact and you're not worried about pelvic organ prolapse. And so I want to make you familiar with options and symptoms to discuss. Now we're going to move on to urinary incontinence, another very, very common issue that women are dealing with. I want to break it down into the two most common forms that we see. We have stress urinary incontinence and we have urge urinary incontinence. Stress urinary incontinence is that you laugh, you cough, you sneeze, and you leak urine at the same time. I have a sign in my office that says, sometimes I laugh so hard the tears run down my leg. And I love that because it's so true, and many women can relate to that. And it also helps bridge a conversation about an uncomfortable subject. Urge incontinence is completely different though. That's the more gotta go, running to the bathroom. You go out in public, you go to a restaurant or you go to a mall and you're mapping out where the bathrooms are because you know that when you have to go, you don't have a lot of time to get there. Those are the two common ones that we're dealing with. In terms of stress incontinence, an increase in abdominal pressure is not tolerated by your urethra and the urine just flows out and leaks. And that comes from a decrease in the musculature of your urethra, which is the actual tube that you urinate from your bladder. Urge incontinence is different. It is not a muscular problem. It is actually more a nerve problem where your nerves in your bladder tend to spasm on themselves. We do tend to see that happen with age and after childbirth. And it certainly starts even in your early 40s. You just can't hold urine the way you used to. And you do have to get to the bathroom faster, and that just increases with age. So in terms of treatment options for the two different kinds of urinary incontinence, with stress incontinence, we have non-surgical opportunities. Again, that pelvic floor PT can make a difference if you have a mild case of it in particular. We can bulk up the urethra. We have office procedures that we can do that are quite simple. But I have here start at the bottom of the slide. The surgical intervention is a urethral sling procedure, and that is the gold standard. Again, same day procedure that really does make a difference in quality of life. For urge incontinence, we do not really have a surgical treatment for that overactive bladder, that gotta go. I have seen pelvic floor PT, again, work wonders for women with urge incontinence. And we also use medicines to kind of stop those bladder spasms. Now, there are multiple medications on the market for bladder spasms, but they can have serious side effects. So you have to have a discussion about what your current medical issues are. And with increased age, we don't always use all certain types of medications. So that's an important conversation to have with your doctor. There's also botulism injections or Botox for the bladder, and that is effective. And there's also a pacemaker for the bladder that can be placed actually pretty easily that can help with urge incontinence as well. This is a diagram of the different slings that we use for stress urinary incontinence. They can go behind the pubic bone or to the side through that obturator foramen. These are done same day, minimal time out. You just need somebody to drive you to and from having this procedure done. And they are an instant fix of any of that leakage that you have when you cough, laugh, sneeze, squat, walk, any of those things. Okay, moving forward, this is the genitourinary syndrome of menopause, GSM. This was formerly known as vaginal atrophy or vaginal dryness. And this is a collection of symptoms that is associated with a deficiency in estrogen. GSM increases most at menopause when those estrogen levels are drastically falling, but it continues as we age. And it's a constellation of genital symptoms, urinary symptoms, and sexual symptoms. As you can see here, estrogen levels decline as we age, and you can see that drastic decline at the age of 50, but you can see even more of a decline at 60, 70, 80. And that is the age bracket where I'm treating women most because the estrogen deficiency is definitely uncomfortable. If you see in the slide on the left, this is woman in her reproductive years, she has a thick, bigger uterus with lots of musculature, a thicker fallopian tube, and a thicker ovary. And then when the estrogen decreases on the right, you see the difference. You see that the uterus shrinks in size, the ovaries shrink. The ovaries are now the size of grapes, essentially. And everything just gets truncated and loses elasticity, all due to the lack of estrogen. Multiple symptoms arise because of this. And those symptoms are different for everybody. So again, every person is different, and anything you feel, you should definitely share those symptoms, because these are very easy cures. The treatment of GSM, gold standard, is estrogen. Now, estrogen comes in many different forms. There's a cream, there's a ring that can be placed in the vagina, and there's suppositories that can be placed in the vagina. And they are all topical treatments. So this is a very important point to understand. When you use estrogen specifically in the pelvis, it does not go to the rest of your body. It's not going to your breasts or your arteries or veins. It is staying topically where we put it, and it's treating the symptoms that are specifically there. So this is different than hormone replacement therapy that goes to your whole body and has side effects and is not recommended once you're out of the first 10 years of menopause. So estrogen is a safe and effective treatment. There are non-hormonal treatments for different irritative symptoms of GSM, and those include any oil that you can cook with. So Chef Alex talked about avocado oil. Coconut oil is really common, and it's very effective for the dryness aspect of it. But it doesn't fix the elasticity the same way estrogen does. So truly the best treatment is estrogen, but those are some non-hormonal options for you as well. Next, we're going to move on to recurrent urinary tract infections. So this is the most common thing that we deal with women as they age, and a urinary tract infection can land you in the hospital, very sick. It's defined as 2 or more urinary tract infections within a 6-month time period. So basically, if you've had 2 UTIs in the past 6 months, you need to tell somebody about that. Or if you have 3 in 1 year, you should let your provider know, because that's an issue. A common UTI is just known as cystitis or urethritis, which is where it's inflammation and an infection by bacteria at the urethra, which is where you urinate from, or in the bladder. A UTI becomes complex when it's associated with fatigue, fevers, you just don't quite feel right, and you could actually have mental status changes. Pyelonephritis is when that bacteria ascends up from the bladder into the kidneys and is higher up and affecting more organs. And that's when you add nausea and vomiting, back pain or flank pain, and pyelonephritis will land you in the hospital requiring IV antibiotics, possibly mental status changes, and is very serious. You're very ill if you have pyelonephritis. I want to remind everybody, and forgive me if you already know this, UTIs are caused by bacteria. And we have good bacteria and we have bad bacteria, both in the vagina and in the bladder. UTIs are very, very common. Up to 70% of women will experience them in a lifetime. And when you experience that UTI, 30% of the time, it's going to recur relatively soon. So it's something you should always look out for. If you treat a UTI, usually with antibiotics, and you're not better, you have to make sure you let somebody know. So I want to introduce to you the concept of good bacteria and bad bacteria. As we age and estrogen declines, we have less good bacteria and more bad bacteria, and that's what can ascend into the bladder and cause UTIs. So why does this happen? Why would there be an age-related increase of UTI? It's all related to estrogen. So what happens is, with that lack of estrogen and that lack of elasticity, the urethra, where we urinate from, actually physically gets truncated and moves closer to the vaginal opening, thus introducing it to more bacteria. Those bacteria are also, in the presence of not a lot of estrogen, will ascend up into the bladder and into the kidneys much more quickly than it would if you were younger with more estrogen in that pelvis. So prevention is estrogen. Again, in any of those forms, estrogen does help to prevent urinary tract infections from occurring. Cranberry supplements had become very, very popular on the market. The problem with cranberry is it's a sugar, it contains a sugar that works on the bladder wall to displace bacteria. from the bladder wall, but the amount of cranberry sugar you would need to ingest is so much, you would probably get diabetes from all of that. So that's not a healthy way to go with those cranberry supplements. That sugar is called D-mannose, and there are newer supplements on the market that specifically contain that sugar that is better for you than a cranberry supplement and more effective. Ultimately, the treatment for any kind of infection is an antibiotic to fight that bacteria, but antibiotics always have those issues of resistance or allergies or side effects. So if you don't have to take antibiotics over and over again, it's really better to prevent them from happening in the first place than relying on antibiotics. Hospitalization is required if there are high fevers that don't go away, mental status changes, and dehydration. So that's something to also always look out for. Those were the common usual suspects. Now I'm going to talk about cancer concerns and what I want you to look out for potential signs of cancer. We're going to talk specifically about cervical cancer, ovarian cancer, and uterine cancer. Those are the main players of the female organs in the pelvis. I'm going to start with cervical cancer, but before I get to that, I wanted to just throw some questions at you and have you think a little bit actively about this. So which gynecologic cancer do we actually screen for? You know, we do all kinds of screenings. We do mammograms for breast cancer and colonoscopies for colon cancer. Well, what do we screen for female cancers? We only screen for one cancer. It's the only cancer we have anything to screen with, and that's the pap smear, and that's for cervical cancer. The most common gynecologic cancer is uterine cancer. And lastly, the gynecologic cancer that is known as the silent killer is ovarian cancer. And that is because that certain common type of ovarian cancer, which in itself is rare, but epithelial ovarian cancer has no signs or symptoms. And you wake up one morning, you're bloated, you have signs of ovarian cancer, and you have stage 3 or 4 ovarian cancer. And that's why it's known as the silent killer. We're going to talk about that a little bit more. But for now, starting with cervical cancer, I wanted to show you what a pap smear looks like in the office. We place a speculum inside the vagina, and at the top of the vagina is the cervix, and it looks like a donut, just a circle with a little donut hole in it. And we take a brush to that donut hole, and we just rub it on that donut, and we send that to the lab to make sure the cells are okay. So a pap smear only tells us about the cells on the cervix. It does not tell us anything about the uterus or the ovaries or the fallopian tubes, only the cervix. And that's what a pap smear is. That is the screening test we have. If you have an abnormal growth on your cervix, what that would feel like is nothing. You usually can't feel that, but you might have symptoms of abnormal vaginal bleeding, vaginal discharge that tends to be very, very heavy, and you would notice that, and bleeding after intercourse. Those are the main signs and symptoms that we see. Again, the screening is the pap smear. Pap smears have changed, and the screening guidelines behind pap smears have changed. In the older days, 20 plus years ago, we always told patients you have to get your yearly pap smear so we can find out if you have any cervical cancer. Well, that was never really based on any science. It was basically come back in a year, I'll do a pap smear, we'll refill your birth control pills, and that's how we'll do it. We now have the science behind it. We've done a lot more research, thankfully, on female cancers. And cervical cancer is unique in that it's caused by exposure to human papillomavirus. And you get that exposure through sexual activity. Human papillomavirus comes in dozens of different kinds, and we split them up into low risk types and high risk types. The high risk types are more concerning for cancer. So when we do a pap smear, we automatically test for HPV if you're over the age of 30. And depending on what your HPV status is, we can figure out when you need your next pap smear. And those are based on national guidelines. Those guidelines have changed. And so if your pap smears are normal and your HPV testing is negative, meaning normal, your pap smears are actually every 5 years. They're not every 1 year anymore. In addition, you can age out of pap smears, assuming you've had everything normal for a long time, meaning greater than 25 years, you can stop pap smears at the age of 65. Now, that does not relate to everybody. Every woman has a different pap smear history, but if you've had completely normal pap smears, they can stop at age 65. I still perform them for my patients. I'm not comfortable stopping at 65. Everybody is different about that, and I would talk to your doctor about that as well for cervical cancer. Moving on to ovarian cancer, There are several different types of cells in the ovary, and those cause different kinds of ovarian cancer, but it's the surface epithelial cells that cause that are that silent killer, where we really don't have a screening test for ovarian cancer. And the newest news on the market is the fallopian tube, as shown here, is located right on top of the ovary and very much works with the ovary during our lifespan. We have now learned that that silent killer ovarian cancer quite possibly is actually fallopian tube cancer, but because those organs are so close together, it's hard to know where the initial cancer started. What we do now is when women are done with childbearing, if they're interested in a tubal ligation, instead of tying fallopian tubes, we remove them. That is a simple procedure that is done that decreases the future risk for ovarian cancer. So should you know anybody, daughters, sisters, mothers, whoever is interested in that, having your tubes removed does decrease the risk for ovarian cancer. Now, ovarian cancer, it's very rare, but if you're interested in that, why not reduce your risk? The biggest signs and symptoms we see of ovarian cancer is bloating, and it's that feeling of your pants being tight, and not because you've overeaten and stopped exercising, but just without any kind of sense, your pants are tight, your clothing's tight, and you feel more abdominal pain and pressure. We do not have effective screening, like I've said. Ultrasounds, blood work, pelvic exams even do not help in screening for ovarian cancer. Somebody doing a pelvic exam once a year is just not going to pick up a cancer. So really, you have to be on the lookout for your body changing and just be in tune. And if in doubt, just talk to a provider so we can work it out. Lastly, we're going to talk about uterine cancer. That's also known as endometrial cancer. The signs and symptoms of uterine cancer is bleeding. So anytime, if you ever have any bleeding, like you're on a menstrual cycle, you must let somebody know. If that should happen, there's 3 things that can be done to work it up. We do a pelvic ultrasound and we look at that lining to see if that looks suspicious for cancer cells growing. We can do a biopsy in the office of that lining. And also something called a hysteroscopy, DNC. Hysteroscopy means putting a camera inside the uterus, where we can physically see inside the uterus and then biopsy anything we see. So you can see in this picture here on the right, you're looking in the vagina through the cervix up into and inside the uterus. And on that normal slide, you can see those 2 dots at the top. That's where the fallopian tubes come in to the uterus. And that tells us that we're in the right spot. You can have fibroids and polyps. These are the common things that we see. But on the bottom right, you can see what an endometrial cancer looks like with that camera. And we clean out that uterine lining to get the diagnosis and then can take further treatment from there. So in a recap of everything we've discussed, and I know it's so much information I have thrown at you, I really just don't want you to assume everything is normal aging and just deal with it. You don't have to live that way. The symptoms of the usual suspects are really vaginal irritation, pressure, dryness, burning, those types of symptoms. Very annoying to live with, and really you don't have to live that way. In terms of the cancers, I always want you to look out for any type of bleeding and unexplained increased bloating or abdominal distension or pain. And those are symptoms that you should share with your providers. In terms of aging well, again, don't assume you have to live with anything. Please don't shy away from discussing your issues with any provider. We are trained and educated to talk about this. I know it's an uncomfortable topic, but we need, if you don't talk about it, we can't help you with it either. And I don't want women living uncomfortably unnecessarily. Female issues equal male issues. So men, please be on the lookout for all these symptoms too for your loved ones so you can help with helping them feel well. And what I see in my practice is my patients who age well are my patients who don't stop moving. So please you have to make sure you move every day. It makes such a difference. But if your pelvis is not at its best, it's difficult to move. It really will affect you. So please reach out and talk about any issues you're having within your pelvis so we can keep you moving. Thank you so much for your attention. I'm sorry about the technical difficulties earlier in the talk, but I'm happy to take any questions if anybody has any questions or comments.
And Dr. O'Neill, if you want to stop sharing,
Sure.
anyone who has questions, please put them in the chat. And I will be able to give these to Dr. O'Neill because we're so lucky to have her. And just know that you will be receiving her slides. So you will have all this information at your fingertips. Perfect. So I'm going over. All right, let's see. How long should you do pap smears? And that's, I think you've already answered that. Some people stop at age 65.
Mhm. It really is dependent on your personal pap smear history. If you've had all normal pap smears your entire life, the guidelines say you can stop at 65. Now, here's where that gets tricky. That study and those guidelines were based on the life expectancy of women being around 78. I think we all live past 78. People say life is short. I think life is long. And so I don't personally stop pap smears at 65 because my patients live past 78 and I continue them at least until 70 and sometimes 75, depending on the patient.
Okay. It does seem that male sexual issues are dealt with more seriously than for women. Do you know if insurance would normally cover the topical estrogen?
So that is the irony of it all is once we hit 65 and most of us are on Medicare, all of a sudden the coverage for all these medications goes away, and that's when we need them the most. Insurance is starting to cover different estrogen products more. Topical estrogen creams are the toughest ones to get covered. That being said, there are two main ones on the market. One is not covered well at all. The other one is starting to get better coverage. There's a new online pharmacy that's also available that makes estrogen creams very affordable. So there are options out there for all the different types of treatment that are actually affordable now.
Could you include the name of that company or that product?
That can be found. It's Mark Cuban from Shark Tank. I don't, if you're
Mhm.
familiar, has an online pharmacy. And so if you just Google Mark Cuban pharmacy and Google estrogen cream, it's available there. It does
Perfect.
require a prescription, so you would have to reach out to a provider, but we are routinely doing this because we are able to get our patients access to medications now because it's so much more affordable.
Oh, that's great. Okay. Do Kegel exercises help with incontinence?
They can. So that's a form of pelvic floor physical therapy. The general Kegel that we teach in the office, however, they're very difficult to do well on your own. It's hard to pay attention to your pelvic floor to do the repetitive nature of it. And that's where I think going to a formalized pelvic floor physical therapist who can walk you through it and help you do it more effectively would be a great place to start. Pelvic floor physical therapy is not like orthopedic physical therapy. You're not in a big room surrounded by people going 3 times a week. It's usually a female physical therapist who's been trained specifically to do this, and that's what they do. It's in a private setting, and they work with you. So if you can just go 1 time a month, they'll create a program for you for that. If you can go every week, depending on what your needs are, they will create a program for you knowing what you are actually physically able to attend. So Kegels, there's a good place for them. They're very difficult to do well on your own, and some further instruction is much more effective.
Okay. Do you need a pap smear if you've had a hysterectomy?
That too depends on what your pap smear history was prior to your hysterectomy and the reason for your hysterectomy. So again, very much individualized per person. If, however, your hysterectomy had nothing to do with cancer, it was for fibroids or abnormal bleeding, and you did not have abnormal pap smears before your hysterectomy, well, then once you've had your hysterectomy, and assuming they remove the cervix, which we almost always do, you do not need pap smears after hysterectomy.
What is the best treatment? And I'm going to completely slaughter this word. What is the best treatment for vulvodynia?
Vulvodynia, yes.
Okay.
So vulvodynia is not necessarily only an age-related issue, but it's pain at the vulva that comes from nerves, actually. And it's a nerve issue. So we use a lot of nerve medications like gabapentin and Lyrica that are used for chronic pain symptoms. Vulvodynia is a very complex issue, and it involves many different things for women. both in terms of when they first start and how they treat it. Pelvic floor physical therapy can be part of it, but women with vulvodynia may not be ready for that right away. There are different topical creams that we use, as well as oral medications that can help. And it's a whole process to go through to figure out what's going to be effective for you.
How can you tell the difference between vaginal itching from lack of estrogen versus itching from lichen
Lichen
planus?
sclerosis and lichen planus. So visually, we look at the vagina and the vulva, and lichen planus has a different look than lichen sclerosis, which has a different look from genitourinary syndrome of menopause. So by visualizing it, we can see which of these conditions is happening, and we can always biopsy the area, you're numb, of course, in order to get a definitive diagnosis as needed. Usually for lichen planus specifically, that requires a biopsy to prove for sure. And the treatments are different for those conditions, so it's important to know exactly what you're treating at the vulva because the treatments are different.
Okay. I am a 73-year-old female. I had a wonderful gynecologist. She changed specialties, and finding a new gynecologist was difficult. Now the new one is gone, and I worry about being told I only need a gynecologist exam every other year.
So, you know, there's no good answer as to how often a woman needs to be seen for gynecologic care. Lots of that is dependent on the woman and her personal issues. In our reproductive years, especially for having children, you just naturally end up seeing an OBGYN because of all the prenatal care. And then when we get into our 40s and 50s, we're dealing with issues of perimenopause and menopause. So we're usually seeing somebody because we're having issues. And then if you have a hysterectomy or you age out of menopause and you're not having any active issues, and I've said before, we don't have many screening exams for different cancers, and pap smears are now every 5 years. That's a great question. How often do you need to see a gynecologist? Even in terms of breast exams, the reality for picking up breast cancer is that it's your mammogram that picks up breast cancer, not a breast exam once a year by a physician. So our guidelines are going to be changing, and I really think it has to be dependent on the woman. Insurance plays a role in that. Medicare covers a breast and pelvic exam every other year. So if you continue to want to be seen every year, there's probably going to be a cost associated with that. Unless you have an active problem. If you have an issue that you're being seen for, that's different. So there's always a uniqueness to figuring out what every woman needs. And I don't have a direct answer for that. Every woman has different desires. There are many women who don't want to go to the doctor and they're happy with every other year. There's other women who are not comfortable with that and want to go every year. And we would just need to find a way to make that happen. But there's nothing routine about gynecologic care anymore. We do a lot of as needed care. And that's where utilizing your primary care physician is also very helpful. Because if you bring up a problem to your primary care physician who you do see annually, they can always refer you to gynecology if there's an issue they're not comfortable dealing with. And that's how more patients get access to gynecologists now.
Okay. I had cervical cancer 28 years ago. My family physician says I don't need one. I'm not totally comfortable with this. I'm currently 70. I had a hysterectomy at that time. What are your thoughts?
So based on the guidelines, your family physician is not wrong. That being said, performing a pap smear on what is left of where the cervix used to be would also not be wrong. And I think whatever you are comfortable with is what you should pursue. And I think that that can be coded and billed in a way, given your history of cervical cancer, that could be done.
Well, the rest are comments. Such great information. So glad your slides are available. And thank you, thank you, thank you.
Oh, well,
So,
thank you. And really,
course.
I really appreciate the attention and all the questions and comments because I don't want this subject matter to be ignored. And if I can ever be of help, I'm always here.
Well, thank you. And we appreciate you so much being a part of this, Dr. O'Neill.
Thank you.
And we will see you next month. How about December 12th? Let's make a date. And until then, enjoy the fall, enjoy our beautiful weather, and continue to live well and age well. We'll see you soon.